emergency war surgery, mass casualty triage, and after that, aeromedical evacuation. So any questions for me before we get started?
Do you open PowerPoint mode?
Yeah, it's in there.
What's it?
Hold on 1 second, Chief. Where's this? Yeah, we'll just do this for now.
Just try to fix it.
All right, so here we go with a couple definitions. A mass casualty event overwhelms immediately available medical capabilities to include personnel, supplies, and/or equipment. What is the amount of people that it causes for someone to have a mass casualty?
Anything that overwhelms the capabilities that you
There is
have.
no specific number. Anything that overwhelms the capability of that medical facility or BAS. So 2 casualties could be a mass casualty for BAS, right, as an example. Or your World 1 facility. The ultimate goal of combat medicine are to return the greatest possible numbers of warfighters to combat and the preservation of life, limb, and eyesight. So what's the best battlefield medicine? Preventative, right? Keeping rounds down range, right? So that's what that's saying. Keeping as many guns pointing down range, as many warfighters able to fight the fight, to prevent more casualties. All right, so your triage categories are immediate, delayed, minimal, and expected. Do I need to go in detail in those?
Yes. They're always on the exam.
Okay.
You can
So,
never
what
get it right.
does that mean?
They're always on the exam, and I could never get them right.
So there's one that throws people off all the time, right? They see a leg amputation, right? The key word is that leg amputation and the patient is still stable. What do you classify that patient as? Delayed, right? I know that one trips up because they'll see a leg amp and the immediate thought in their head is, oh, emergent. But it's this patient's status with whatever injury is going on that's going to dictate what that triage category is going to be.
Alright, so what does triage mean? French word that means sort. We'll figure things out. So system of sorting and priority casualties based on tactical situation, mission, and available resources. So immediate requires attention to in minutes, hours to avoid death, in need of surgery for delayed but can delay treatment, sustain treatment, minimal minor injuries, walking wounded, and then expectant those who have injuries so morbid or so extreme that they're ultimately going to pass away. Slide, please, good sir. So triage minimal injuries that are evacuated to a surgical unit should not be brought through the resuscitating area. So all of the casualties should be divided to emergent, non-emergent, and expectant. So again, when you're setting up your CCP or casualty collection point, you want to make sure that the flow of traffic is such that, okay, you're expecting to go one way, so obviously those people who are still able to see those patients that aren't freaking out, screaming their fellowship mates, friends, soldiers, sailors, etc., injured, vice those who are going to need surgery and so on and so forth. So special triage considerations, chemical, biological warfare, retain unexploded ordnance, non-combat local or third country nationals, enemy POW detainees, and then contractors. So a lot of times with contractors, especially when you forward deploy, many times some will have a status force agreement or some type of MOA, a memorandum of agreement, so where they can get seen or treated out facilities. That's not always the case. Most times when contractors are injured, then their respective companies deal with that and move them accordingly. Some more special triage considerations. So combat stress, rapid identification and immediate segregation of stress casualties from injured patients will improve the odds of rapid recovery. With expeditious care, these casualties can be returned to duty 80% of the time. So notice, they're in bold. Pay attention to those.
So what that means, right, to kind of give an explanation. So for your expectant patients, right, if you're seeing dead bodies or close to dead body, people dying, right, what was going to happen to your own body? Your blood pressure is going to go up. Your heart's going to start racing faster. So somebody that was maybe stable in that situation in that non-emergent category is now going to fall unstable and now push them into that emergent category. So that's where that segregation increases the recovery and stress levels to get to that 80%.
So you're going to place patients in 2 groups, light stress, heavy stress. using the biceps in mind. So brief, immediate, central, expectant, proximal, and simple. So keep interventions 3 days or less. Treat as soon as possible for immediate. Central, keep in one area for mutual support. Expectant, reaffirm the expectation that the member will return to duty. Proximal, keep close to unit. And then simple, do not engage in psychotherapy. Address present stress response and situation only. Does that make sense? Do I need to go in depth in any of those explanations? Next slide. So again, a lot of these triage decisions can be influenced by multiple factors. So external factors, tactical mission situation, resupply, and then time to of evacuation. So internal factors, med supply, space capability, personnel, and then stress. These are all factors that play a role in triage. Who here has been with the Green Side unit or deployed, been to a combat zone? Those lines. So a lot of things have changed over the last few years, and we're moving towards that maritime environment. So with your deployment Marines, you do a MU, OKI. So you guys are still going out, mirror mission sets, so on and so forth. So in the event when you guys will push forward, you and your respective platoon Marines and your C line, when your C line will be back with headquarters element, set up a CCP, right? In the event when you guys are operating, so in the event that somebody gets injured, okay, you'll come back to the BAS or wherever you guys set up shop, treat that patient accordingly, and then push forward with the mission. That's essentially how the flow went. Alright, so the following critical triage decision making. So vital signs, pattern injury, response to initial interventions. So initial vital signs. A lot of times when you're in a combat environment, it's loud, noisy. You want to get the best vital signs you can, get that person off the X. Right, you may not be able to oscillate, but what can you do or to get their vitals? Alright, so blood pressure over palp. So if they've got a radio pulse, what is considered? 90. Okay. Femoral. 60. Yes. All right. So get those vital signs, pattern of injury, and that depends on if it's a multi-system trauma, if it's trauma, if it's a single gunshot wound, amputation, whatever it may be, a blast injury. So and the types of injury. So depending on the mechanism will depend on triage categories, and then your response to initial interventions.
So I put the chart on there because the types of injuries has been on the test before, where it'll say what's the number one type of injury in a battlefield scenario. So just know that's going to be your penetrating injuries.
You say penetrating chest wound?
Well, it's just going to say penetrating on the test.
Next one, Drew.
Yes. All right. So mass casualty triage. So set up staffing and operation of triage system. So initial triage area. Single triage area, officer. So when you set up your CCPs or casualty collection points, typically you want to have somebody standing at that front door as a gatekeeper, right? To as the patients come up, triage them accordingly and factor them to the necessary places where they need to go. If they're expectant, if they're minimal, or if they're immediate, delayed, so on and so forth. So the initial triage area should be in proximity to receiving area, one-way flow in and out, well-lit, climate control, dedicated casualty recorders, and sufficient litter bearers. So when it comes to litter bearers, who do you want those personnel to be? Non-medical personnel, right? Because what do we need you to do?
Treat the
Treat the
patient.
patients, treat the casualties, so on and so forth. So for your Marines, your sailors, those non-medic or foreman rates, those who you want your litter bearers to be so they can pick up patients, move from point A to point B, so on and so forth. For your recorders, that'll usually be your SEALs or another junior HM if they're not in there doing interventions. But when you come up with your triage plan, you designate those roles for each person, who's going to do what, do where, so there's no confusion. Everybody's not trying to figure out what last thing.
That same concept is why your dental officer is usually your default for triage officer, because you need your MOs actually providing the treatment to the patients, and that's why they're going to run the triage.
So your emergency treatment area, you want to set close proximity to initial triage area, having personnel to record casualties, multiple resuscitation bays, ACLS, capable. So we know what ACLS stands for. Advanced Trauma Life Support. Staffing at row 1, most experienced provider is mass casualty team leader. At row 2 is going to be chief of trauma, design, surgeon serves as the chief surgical triage officer.
Chief, can you explain to them, because I know some of them don't know what the difference between role 1, 2, and 3 and 4 are?
So a row 1. A row 1 is essentially basic first aid care. So that'll be your BAS, right? That's considered your row 1 because you don't have any surgical capabilities. Row 2 is a step up for that to where you will have, surgical capabilities with minimal specialty services, i.e. lab, x-ray, things along those lines. Once you get to a row 3, then you have some more specialty services involved in more surgical specialists where you may have, OB-GYN, you may have urology, psych, and a row 4 would be like your major medical facilities. So like Bethesda, we consider one. Is Launchtool considered a row 4? I think, or is
Who?
Launchtool? I think it's still considered a row 3.
Still row 3.
But pretty much coming back to those large medical facilities who have all those specialties. For instance, like with Bethesda, they have like plastic surgeons, so on and so forth. So they're as you go up in tiers, the medical capabilities and things that you can do increase. Does that make sense for kind of like a dumbed down version of that?
And including in that role 1 is also us on the X doing what we can while we're getting to the BS. So BAS and us on the scene are considered that same category.
So these are some pictures, example of a triage area. You have your initial intake, expectant, non-emergent to go to their separate areas, and then those emergent, those patients, casualties needing, further care, treatment going to there, and they're from there probably to the surgical suite or where they need to go from that point forward based on once they receive and the providers get in and make their assessments for that patient. So non-emergent treatment areas, last search, so your small injuries, things that can be treated very quickly, give patients back out to the fight, put 4 rounds down range. Expectant, ideally, casualties kept away from other treatment areas. Team leaders can be anyone capable of administrating parenteral payments. So why do we want to give these people payments?
They're carrying stuff, it's a set of it, they don't
So they're not suffering.
Yep.
Okay, we know they're gonna die, we want to make sure they go peacefully, we don't want them suffering through that trauma. What was that?
Palliative care.
Yes. Additional triage operation tips. Be mindful of workflow shifts, provide patient nurse fatigue, have the mass casualty plan in place, and practice it, utilize after action reports to improve process. Alright, so